are seeing.
Hi, I'm Brad Power, and I'll be moderating today with Brian McCluskey, and we're proud to have Payel from SEngine leading us today through a discussion about organoids.
Hi, and hello, everyone. So I'm the principal scientist at SEngine, and I basically manage the drug designing and the report team of the Paris test. And the title of my talk today is Personalizing Cancer Treatments with the Paris test for solid tumors. So the name Paris comes actually from mythology, is basically how Paris actually killed Achilles by shooting on Achilles Hill, and because that's the place Achilles was most vulnerable. And that's the whole concept of SEngine Precision Medicine, that finding out the unique vulnerabilities of every patient's tumor so that we can target and basically treat the patient with those unique drugs. So to this group, it's not unknown that even though there has been advancement either through DNA sequencing or through FDA-approved therapies or different treatment approaches like brachytherapy, proton beam, gamma knife, we still lose a lot of people every year from this devastating disease. So a lot more still has to be done. We are not there yet. So in SEngine, this is our CEO, also the Chief Scientific Officer, Dr. Carla Grandori. She believes, and then we all believe, that every individual's cancer is a unique mosaic of molecular changes. So what I mean by that is, as you all know, that cancer is happens while we are having a lot of molecular changes, meaning either gene mutation, amplification, fusion, or maybe some sort of mutation. But every patient's tumor, no matter which type of cancer we are looking, always present us a unique constellation of genetic changes. For example, if we see colorectal cancer having KRAS mutation, no two patients are same. We have seen KRAS mutation along with P53. We can see KRAS mutation with CDKN2AB loss. For prostate cancer, we have seen androgen amplification along with BRCA1 mutation, androgen amplification with SPOP mutation, androgen mutation with ATM and SPOP. So there are like plenty of, you can say, permutation and combination of different genetic changes. And that's what made every individual's cancer is almost like a unique disease.
Payel, are you advancing the slides, or are you speaking to this one slide?
No, I am. So, oops. You guys are not seeing?
No, we were only seeing the first slide. Somehow it wasn't advancing.
Is it?
Now we see, it says breakthrough technologies for the next generation precision oncology.
So how about, do you see the next slide?
Yes, now it's working.
Okay. Now I don't know how to go back. Okay, yeah, it worked. Sorry. So this was the previous one, Dr. Carla Grandori, who I think some of you have already met her, but many of you have not met. So I just thought I would throw a slide on that. Now you see again the breakthrough technologies, right, Brad? Mm-hmm. So I would give a little bit of a history that how SEngine was founded. So SEngine was founded based on the rigorous scientific research happened in Fred Hutch Cancer Center. So our co-founders were actually principal investigators and like all the professors in Fred Hutch, Dr. Carla Grandori, Dr. Chris Kemp, Dr. V.K. Gadi, who is actually a breast cancer surgeon, and also Dr. Eddie Mendes, whom we actually lost due to cancer itself. So Eddie was one of the founding member of SEngine and who passed away within 2 years after battling the cancer, unfortunately, but his vision still continues through SEngine. So um, in SEngine, what they did in the lab was basically trying to grow the tumor organoids outside the body. So we would get the patient sample and try to grow in 3D in the form of organoid, meaning you can say like clumps of cells, clumps of tumor cells in 3D structure. And then we merged that with the robotics technology for drug screening. We give the drugs to those, or we treat the organoids with drugs. And then over 6 days, we basically treat those organoids. And at the end, we merge this result with our unique bioinformatics technology, and we rank all the drugs from 15 to 1. Every drug gets a score, unique proprietary score, which we called SPM score. It's basically SEngine Precision Medicine score, so that's why it's called SPM score. So our test is unique because it's a CLIA certified first-in-class pan-cancer assay, and it's a functional assay rather than more of a predictive assay. We actually test the drugs on which we are reporting, and we don't discriminate patients based on the previous line of therapy, meaning we have patients who had multiple lines of therapy, like even up to 7 or 8 lines of therapy, and we would be able to still find an exceptional drug for that patient. And we provide a report at the end to oncologist, which gives the drug sensitivity unique for that patient. And we are also CLIA certified. Only the New York state is pending, but other than that, all 49 states we have, our test is certified, and we're trying now for the insurance reimbursement. It might still take a little over a year, but we are taking baby steps towards it. And we are also involved in multiple clinical study across the whole world. We have a clinical trial in France with Gustave Roussy, one of the leading cancer institute there for colorectal cancer. We are part of 2 clinical trials in University of Washington, cholangio, and University of Chicago cholangio studies. And also we are a regular member of University of Washington's gynecology, oncology department's tumor board, because we sit there and discuss with the doctor what might be the next step for the patient. Next slide. So here I basically describe that why we think our test is superior to DNA sequencing. So as we know that nowadays it's kind of common practice that if a patient comes to the clinic, normally they get genetic testing. But even the patient, when they get genetic testing, it's only 18% of cases the DNA sequencing can predict a drug. But in our case, it is at least 75% of chance that we would be able to predict a drug. So what I mean by that, like for example, if a patient goes to the DNA sequencing test and saw BRCA1 or BRCA2 mutation is present, then you know, or the DNA sequencing can predict that PARP inhibitor might be beneficial for you. But you don't know which PARP inhibitor would be beneficial for you. There are 4 different PARP inhibitors. One might be better for your patient or for your tumor type or your, like the stage of the disease you are in, compared to all 3 others. So what we do, we test all 4 along with like ATR inhibitor or platinum, and we can tell you that which exact PARP inhibitor would be beneficial for your tumor. So I think that that gives the power, and that cuts out the whole guess game, because you from the beginning, you know which drug would be best for that patient's tumor. And that's why we see, yes, yes, Rick.
Oh, thanks. Uh, is your testing limited to small molecules?
Yes, currently we only do small molecules. We do both targeted therapy as well as chemotherapy though. So like even if I said small molecule, we do test chemotherapies. Currently we don't do immunotherapy. Unfortunately, that's under the process. We just hired someone who has an unique experience from immunotherapy. So he has immense experience of culturing immune cells with tumor cells. So we are starting there, but we are not yet there. And same for monoclonal antibodies. We have tried before for the HER2 part, like trastuzumab and all we could do, but it's a little bit trickier to test it in ex vivo or in vitro systems. So that's what I think is we are trying to figure out.
Thanks.
So for prospective and retrospective concordance, because we could predict a drug in almost 75% of cases, we do see a very high concordance with the prospective concordant with prospective studies where the patient had received a drug guided by Paris test. And we have also seen over 80% of retrospective concordance for the patient where the patient has seen a drug already and progressed on that drug. We could see that our SPM score would be very low for that drug. Also, we have seen if a combination didn't work, for example, FOLFOX didn't work for the patient, we could totally see at least either both fluorouracil, the FOL part, and the OX, like the oxaliplatin, when tested separately, either both of them performed poorly in our test, or at least one performed very poorly in the test. And that's when you know the combination is not going to work. And this we see very, very regularly across the tumor type. And we do very rare type of tumors also. So before SEngine, all my life I have done prostate cancer research. Brian and Brad knows I've discussed. But then after coming to SEngine, within 2 years, I got exposed to so many different type of cancer that I never knew that those existed. So we don't discriminate. We even treat or make organoid even if a cancer is never heard of. So I think that that's what is our test strength, I would say. So next slide. I hope you are still seeing the next slide, right? Please let me know if it is not moving.
Matching the right drug with the right patient.
That's correct. So that is our motto, matching the right drug with the right patient. Because we deliver a clinically actionable report within the clinically relevant time frame. So it not generally takes 4 to 6 weeks, although it depends on the starting material, meaning if the surgical resection or the biopsy material is very poor in quality or very limited amount, then the chances of success obviously would be lower, and also the time frame might be extended. And in certain specific tumor type, as it is a little tricky to grow, it might take a little longer. But in general, it is between 4 to 6 weeks. And along with the proprietary SPM score, which ranks from 15 to 1, we also give the categories for each drug, exceptional, good, moderate to low. So it's like exceptional, meaning where the scores are 15 and 14, those comes as exceptional drugs. Then good is 13 and 12 generally. So that's why we curate every single drug, even if it is actually curated through our algorithm. There are at least 2 or 3 report team members who are scientists, has immense knowledge on the cancer biology. They would curate every single drug and check if it is actually matching with our call. And we give the conclusion in the report in the written format. And then if there is any genomics information available, then we also integrate that in our conclusion portion, meaning if a patient has BRCA2 mutation, for example, we saw one PARP inhibitor over others, so we would explain that we have seen PARP inhibitors and the patient has a BRCA1/2 mutation. Sometimes those concordance help the oncologist to choose the drug, or gives the oncologist maybe better confidence in our test. And we have seen that a lot of time, I think they believe more if you see a genomic concordance. But even if the patient doesn't have genomics, because we regularly get sample, especially for University of Washington now, that as soon as the patient get diagnosed, they sometimes send us the sample, or they're on the first line of therapy when the genomic testing has not been done yet. We get the sample and we are still able to match a drug. And later on, like maybe after 4 weeks, the genomic report comes on, and then they would know, because they would be surprised to see the result that, oh, why this drug came up. And then they would see the genomics report, and that would give them the answer why that drug came up. It has happened like multiple times.
Brian has a question.
Yes, Payel, does the accuracy of the test change based upon where the patient is in the journey? So if they've been under more selective pressures versus less, does that impact the accuracy?
No. So like we have, I would show you some example today to you for our for our exceptional cases, if you may say so, and one prostate cancer case. So we have seen newly diagnosed cases for our cholangio trial I mentioned. There, the patient would still receive the first line of therapy, but they would do the test right when the diagnosis happened pretty much. But then when they progress through the first line of therapy, they would use our test result to give the second line. And we see that very regularly that, okay, the patient has never received, for example, gemcitabine. They normally give gemcitabine and paclitaxel there, or gemcitabine and cisplatin. The patient has never seen either of those, and we would see a resistance in one. And after some months, when we are talking to the doctor, they would be like, oh, that patient progressed, so we put on your top drug. So that happened, and we have seen patient who has come along like really a long time, like the patient is in hospice, but still got our drug as monotherapy. I'm going to show that case, and still surviving over 2 years now. So
Rick has a question.
yes.
So this is fabulous. I'm really excited. I hope to get some fresh tissue up to you.
Yeah, that's the key. We unfortunately need fresh tissue, or the biopsy sample, or the fluids.
Yeah, it was all heading that way until I got a lower PSA, but I'm still I have three or four scans that are out to UCLA, UC San Diego with Raina McKay and Tanya Dorf at City of Hope, all to determine whether I could get a resection of one of my tumors in my lymph node. But anyway, thank you. I'm bubbling around because I'm excited. But the question was, is there a sample report that you could share? Because it's super interesting and I think it'd be great. Yeah.
I'm going to show some of the cases, like exceptional cases. One of the exceptional case, we are hopefully, I would submit it like this month, just because I think I'm doing multiple things, so it's harder to publish it. But then we have one case, I think that's in review, but you can still access through the I think BioReeves, that's what they called. So I can send out that link. That's a PDAC cancer, pancreatic cancer with a HER2 amplification. Actually, the patient's tumor got cured. We saw the HER2, HER2 drugs. We had like lapatinib and niratinib. The patient actually got trastuzumab first and then DNA vaccine, but still that worked, because we first saw that HER2 targeting drugs would work. Patient could go on a clinical trial where it had DNA vaccine, and 5 years later, they, like, I just spoke to the doctor in ASCO, and they're calling her every, I don't know, 6 to 8 months, because they can't believe it, that they can't see any tumor. So they're calling her and they're scanning her, but then it's been 5 years, they couldn't find anything. So we do have certain cases, and I can definitely share the links and
Thank
like
you.
those reports.
Payel, I have a simple question to bring this home. So Rick has identified 7 therapies that he's gotten from various sources, including CureMatch, and
No,
no, not CureMatch, but anyway, 7 from various sources. His medical team. Brian has 17, I think, and these include drug combinations from CureMatch. And so the stage that they're at, where if their PSA were to rise and they were to need to go on to a next therapy, they have a ready-made list of drugs that they would want to test. Is that a use case for the organoids?
Yeah, we can. So we always give priority to doctor's choice. So if the doctors has some drugs which they want to test, or if the patient wants, like, these drugs, I would like to test those drugs on my organoid first. So we would always give priority. So if they already have a list, yes, we have a whole drug library of 200 drugs. And from that, we choose, I'm going to explain the workflow, how it works, so you know, but then we definitely can give priority for the drugs they want. And for combination, we do combinations studies, but it's little limited now, just because we are also very small in hand. So we're kind of like trying to expand this year so that we could do more. It's mostly one drug is at IC30 concentration, meaning 30% of cells get killed, and then we combine the drug B, C, D with it in multiple doses. Like, for example, for prostate cancer, you'd try to combine it with enzalutamide, might be the first drug at 30% concentration, because most of the patient must have seen that drug at some point. And then I combine, like, for example, I'm just giving here, maybe PARP inhibitor, or like some chemo. So we can test that way.
Thank you.
So to go ahead with this picture you are seeing, it is a 3D structure of an organoid. It's basically the clumps of cells. There are no immune cells or any other compound. We select, or we enrich the sample for tumor cells. But what we have seen, that it does maintain tumor heterogeneity and recapitulate the physiology of human cancer. How am I saying this? Because we have to, as per the clear requirement, we have to send every tumor organoid, we culture and send out a report for whole exome sequencing, like genetic sequencing. And we do confirm the mutation we see in the patients, like that should be confirmed in the tumor organoids. Then only we're allowed to kind of send a clear certified report. So we definitely confirm that whatever we are growing is at least a tumor. And there, as you can see here, there are exceptional 73% success rate in growing patient-derived tumor organoids across 30 different tumor types. I think by now we have grown, it's close to 800 cases. So it's not a very minute number. So this is a general workflow of Paris test, where the first step is obviously to collect the sample. The only 2 criteria are that the sample has to be fresh, and the sample sample needs to be at SEngine for within the 48 hours. That's generally not a problem unless there is a big snowstorm, because we get samples from France, from Switzerland, from Norway, US and Canada is definitely not a problem. We also got sample from India. At some point we had a collaboration in Australia. So this can be totally done. And then after we receive the sample, as I mentioned, we purify the sample and we enrich it for tumor cells, and we grow the organoid. Generally very short time, is within 2 to 3 weeks. generally they would be ready for a drug screen. And we use a robot for delivering the drugs to the organoids. And over 6 days, the drugs are there. So the organoids are incubated with the drugs. So for a full plate, we generally test almost 42 to 43 drugs, which can have either FDA-approved drugs or other small molecules. If the doctor has some request, it's also based on if available patients' genomics, any drugs which are in clinical trial and is available in our library. Because our test is CLIA certified, we have to validate every single drug we use. At least twice a year, we have to send it to separate labs so that they would also test and give us the proficiency testing result. So we can't, that's why we can't test one of our drug which is in clinical trial and it's not in our drug library. But generally that is a very, I would say that's very rare problem, because it's most of the time we either have that exact same drug or maybe at least the same pathway targeting drugs, a very close match. And then we have our bioinformatics team who does analysis, and we have an app internally where the data gets stored, and it's mostly all the drugs get ranking for each patient from 15 to 1. And then we give exceptional, good, moderate, low category for each drug in the report. We provide multiple page report with the top drug table, with a conclusion, and basically explaining the whole report. And if needed, we also sit in the tumor boards and sit with the doctor and the patient to explain. It's mostly with the doctor to explain and to guide them if they need any help in any
Brian
help.
has a question.
Yeah, so Payel, relative to the treatment ranking, do you factor in time, response time? So for example, if I'm considering carboplatin versus apalutamide, would you be able to say, we expect you would get X amount of months of benefit before a PSA rise with one drug versus another drug?
Yeah, so we can't say the exact time, but what we can say if it is a full response or a partial response. So we have seen multiple times that a drug won't give you full response. So that said that, okay, there is a significant higher chance that you probably would develop a resistance much sooner than a drug where we are seeing a complete response, meaning 100%. So it's just yesterday I had a talk with for another patient who I think was on paclitaxel, and we saw that has a only 50% response, a very huge amount of the cells are resistant. So compared to another targeting drug which had 100% response. So that's what we would be able to tell you, that there is a very high chance that you would develop resistance much sooner. So
yeah, and then
telling
I
exact
think
months would be harder because you know our body is not the same like we like in vitro, right? So
well, yeah, maybe there's like a distribution curve, but that's probably
like the drug the problem with that is drug metabolizes differently, and I think it sometimes also differs from patient to patient, so you don't know, and then also the side effects, right? So not every patient's tolerating power is same, not every patient is in perfect health all the time to tolerate all the side effects, so that does matter a lot. So
and I think I'll ask one. I think Ali had a question regarding combinatorials. So for example, I have 3 drug combinatorials, 2 drug combinatorials, and mono. Can you look at the predicted response of 3, 2, 1 combinator, or the various,
we can do 1 and 2. 3 I think we have only done in very limited cases. 3 might be a little harder, but 1 obviously we do that. That's the standard test, but we can do 2. For that we still have to do first the 1 to know the concentration for that particular patient, what is the concentration or how is the response for the single agent. And then only we can do the combo. So we can do 1 and 2. Like for example, the example you said, like maybe carbo and Taxol or carbo and enzalutamide. So we have to do single agent first, and then I can do like enzalutamide and carbo together, or enzalutamide and maybe you were thinking Taxol together, like that way.
Yeah, this may be a little bit advanced, but can you look at effects over time? So can the organoids be preserved so that you can look at, adaptive therapy? What's the right dose? When's the right time to use it? Essentially model adaptive therapy.
Yeah, that's a very good question. So the thing is, most of the time we use up all the sample, because biopsy sample is not enough always. It's very small amount. But if in the case of like we have some samples left, we definitely keep it. But the only thing is, I would say that in the journey of patient's tumor, when you have seen some of the drugs, sometimes the response changes I don't say very dramatically, but like the response changes. Like we have patients where we have done the test 2.5 years ago, and we have done it now after the patient had seen multiple other therapies. And you could see totally the drugs which were exceptional before 2.5 years ago now dropped towards the low, but there would be still some pathways which were at that time also in the good category, and it's still in the good category. So then, but then in that case, we had 2 different samples collected in 2 different times of disease, and that kind of will tell you, like our test is matching with that can tell you that, okay, at that point of time, maybe those pathways were the driver pathways, but over the time that actually got changed. And we also had patient who went on our guided therapy and was doing fine for a year, and then they progressed. So the doctor sent us the sample again, and we tested, and now we can see the drug which was 15 or 14 before, now it's 12. So we could say that there is a shift. So now maybe the combination would be best if we see some other drugs coming up as like 14, or that's the time to change. But then unfortunately, I think the previous frozen sample won't be very beneficial at that time, because there was that time of the disease you collected it, right? So it kind of changed over the time. So we might need fresh tissue at that point of time.
Yep. Okay. Thank you.
Ali also had a question on toxicity.
Yeah. Oh, sorry.
Just like, how do you measure toxicity?
Yeah. So we don't, unfortunately, it's outside system. So we can't measure the exact toxicity profile, but we do have, because we sit in the tumor boards regularly with multiple cases, so we kind of now have an understanding that which drugs might be generally toxic for patients or hard to tolerate. So if those drugs come up as top drugs and we are in the part of the discussion, we always tell the patient that this might be toxic to tolerate. But then it's kind of sometimes hard to say, because we have told that, but then we have some patients who are doing fine in that combination for over 6 months now. We recently had a patient who went on MEK inhibitor and EGFR inhibitor combo, which generally MEK inhibitors are known to be toxic. But he is doing extremely fine over 6 months. His wife is like constantly sending us messages and extremely thankful. So I think it sometimes also unfortunately depends on patients. So at this point, we can't say toxicity for that particular tumor, but maybe over the time we would be. So if I quickly go, then the next one, in ASCO, we have already shown that a Paris test report impacted the physician's decision-making in 62.3% of cases. And we've done a prospective cohort on our alive patient. At least the median follow-up is 10.7 months. And then we had the clinical outcome showed at least almost 72% of cases, the clinical concordance. So these, as I was explaining, this is one of our star case report. This is an ovarian cancer case where the patient came to us in beginning of like, I think here, where you see this as Paris. It's kind of like in the mid 2020s, the patient came to us. As for prostate cancer, PSA is the marker. For ovarian cancer, CA125 is the marker. And you can see that during the Paris test, the patient's CA125 was at 320 and the normal level is here, it's like 30-ish. So obviously the patient was in hospice, nothing worked, she was not able to eat properly, she had a obstruction in her stomach and bowel. So she was in like very high dose of pain management medication. But we did the Paris test, and the top drug was ibrutinib, which is a BTK inhibitor and generally used in liquid tumor, not in solid tumor. So when we saw the result, obviously the doctors were also very surprised, but the patient luckily was a part of VA health program, so she could achieve the drug very quickly. And within a month, she went on the drug and she had some drop, but as like she had a little bit of trouble in initially in tolerating the drug. So she took a small pause during, I think in the early December, but then she managed it well. And then she started again using the ibrutinib as single agent therapy. And this is just part of the timeline. You can see from 320 drop to 16 and 18, the patient is still alive, going to like she has already visited New Orleans, I think last year sometime when her CF125 was so low. We just heard from the doctor last month, not last month, when I was in our ESCO. So it's literally like May end, that she just started showing the signs of progression. It's been from 2020 August till now. She was on that monotherapy, out of hospice now, no pain medication. And she just started showing the signs of progression, and her CA125 rose to 200. But they put her on the second best therapy revealed by Paris test, which was afatinib, another EGFR targeting drug. And her CA125 already dropped below 90, just 1 month use. So she's still on a Paris guided therapy and she's still out of hospice. So let's see what happens next. But we would say that this is a really amazing story, that she was in hospice and because of like our drug selection or the top drug, she's still living and doing fine.
So
Ask,
did
go
anybody
ahead,
have a
Emma.
question?
what was the indication for even try ibrutinib?
That's what I was going to ask.
So that's where our panel is unique, because I did mention that we do, we pay attention to like the genomics, FDA-approved drugs for that cancer and all others. But then we also make a very comprehensive list where if a drug has been approved for other cancers, we would put that drug there. And right now, I think at least almost 10% of our cases were actually responsive to ibrutinib. And I went to ASCO, and I was just telling Brad and Brian, I met a prostate cancer surgeon from Cleveland Clinic, and he told us it seems for prostate cancer also they are seeing it. So we keep a close eye on our patient cohort. So initial days, they used to test all 200 or 100 plus drugs at least for every patient tumor. That's how we do have a database and kind of an understanding that which drugs might be beneficial, even if it's not approved for that cancer. And that's how we see a couple of drugs which comes up. No, I won't say like every single patient, but often. And we always make the list very comprehensive so that we include those drugs if we can. If we can do a full plate, then we would definitely, even if it's not a FGFR mutation, we would have a FGFR targeting drug, just because you don't know if that patient tumor is uniquely vulnerable to the FGFR pathway therapy.
You mean EGFR in this?
In this case, it was
so basically what you're saying, there was no particular mutation from...
No, the patient only had a CHEK2 mutation. We checked the BTK, there was no mutation per se. There has been only one report where a patient had a concurrent CLL as well as ovarian cancer. In that case, they were using ibrutinib for CLL management and the CA125 dropped. So there had been only one case, but I think the genetic mutations didn't match. And now I think our UW ovarian group is starting a clinical trial actually on the ibrutinib. They have already written it. So it's you can say it's like without the Paris test, there was no way to find it. And the same thing happened yesterday. There was a gastric cancer case and belinostat was the top drug. And they were also very surprised. We work with this small management group and they were like, we had no idea that without the Paris test, we would have never predicted that belinostat would be beneficial. So that's how we design our drug panel so that it is comprehensive enough that we would be able to find at least one exceptional drug in each case.
I see. Sorry for interrupting, but I had a case, worked with a case of ovarian cancer, and she had an unusual mutation in STK11, and she had SEngine test. And
oh yeah, I remember the case.
You remember that, really?
Mm-hmm. Is it that New York patient?
No, she was from San Diego.
San Diego, yeah. I think we had like two different STK11. One was from New York, so that one the patient was very sick. So, but then still able to receive our drug. So
she did, yeah. The patient I worked with refused to participate in a trial that was in UCLA. Actually, it was decitabine.
Okay, yeah.
Very sad, but I remember just being surprised that this.
Yeah, we get this surprise pretty much every day. I would believe you. Like we ourselves won't be. So it's like very hard to train a new person because I was training someone under me and then they thought one ovarian cancer responded to these drugs. So the next one had very similar mutation, would respond to similar drugs. But then she saw the result and she was like calling me up, asking that if everything is right. And I was like, this is what is the learning, that you are never biased while you are doing a SEngine test, because you don't know which surprise would like come up.
Mm-hmm.
So this is another case of a very terminally ill cholangiocarcinoma patient. The patient actually had a FGFR mutation, which is targetable for cholangiocarcinoma. The patient has seen ardafitinib, which is a FGFR targeted therapy, and progressed through 5 lines of treatment, but nothing was working. And in 2019, a team of oncologists actually suggested Paris test. And when we did the test, the top drug was dasatinib, which was again used in BCR-ABL mutated tumor, mostly in leukemias. And that had an exceptional response. And the patient was able to receive the drug and her ascites, pain, and tumor markers were controlled for several months. Eventually, as the patient, I already said, was very terminally ill and cholangiocarcinoma is kind of an aggressive one. So I think if we would have had more time, it would have been more beneficial, but she lived still for several months when her life expectancy would have been just in weeks. So there was.
I don't know how many more slides you have, but we have about 10 more minutes.
Yes. I'm just trying to make it hurry. There are not much. These are all these interesting cases. So this is another case who was again a colon cancer patient, and we were able to find gemcitabine, which is a common chemo. Patient took it, and you can see in the scan here that the tumor was reduced. The patient lived after that was 9 months when the doctor almost gave up. There was like no therapy they could choose or predict. So this is again another interesting case. So now for prostate, currently we don't have an established relationship with a prostate cancer group here somewhere. So we had participated in a study with Dr. Himisha Beltran before, where they I think started the organoid. We grew it again in our lab and did the drug screening for neuroendocrine tumors. And other than that, we have done at least 4 prostate cancer patient samples through SEngine, and all 4 of them we received 4 and we could do all 4. So, oops. I don't know what happened suddenly, sorry. So as you can see here, for prostate cancer, we have the 100% success rate. I know the numbers are low, the sample we received and drugged or plated, but in all the cases we were successful, and we do a lot of sarcoma, ovarian, melanoma, breast, like all others. So I'm giving an example of a prostate cancer case we did. So this patient was a 63-year-old male with poorly differentiated prostate adenocarcinoma. And as you can see, the patient had received FOLFOX, paclitaxel as first line, then had FOLFIRINOX, then had recurrence, then received carboplatin and fluorouracil, and then had radiation. And after that, we received a lymph node excision and sample was collected for Paris testing. But even in this case, after these many lines of therapy, we did see an exceptional drug with a score of 14, which was cobimetinib, and it was concordant with the patient's genomics. The patient has a KRAS mutation. So as you can see here, other than the cobimetinib, there are multiple other drugs which also came up. And also we saw enzalutamide with a score of 12, which the patient can still get it, maybe in combination, which would be better in this case because it is not the top drug. We also saw other indications, like for example, the patient had a ATM mutation, and with ATM mutation, it's always controversial that the PARP inhibitor would work or not. In this case, we tested both niraparib and olaparib, and we saw niraparib had a low score, so meaning it should be used in combination, but we could still detect the sensitivity in the top drug. So without the genomic indication, we also revealed the sensitivity for these other pathways. So you can see the PI3K-AKT pathway was one of the prominent one for these patients' tumor. We had alpelisib targeting PI3K, ceritinib had IGF-1R targeting drug, and the AKT targeting capivasertib all came up, along with azacitidine, an epigenetic drug. And I think the patient actually was very interested in receiving azacitidine because he learned about less side effects the drug has. So I think at some point that's what he was planning to get as the next line of therapy when I last spoke to him. So for the chemos, as you saw, the patient saw FOLFOX, FOLFIRINOX. And I said before that if one of the drug in the combination does not work, then we don't see the response. So the fluorouracil, for example, had only a score of 4, which is very, very low and poor. And you have seen that patient has progressed before on FOLFOX, which oxaliplatin was low, but still had a score of 10. We give score for top drugs up to 9. So the SN38, which is the renothecane or FIDI part, that also had a score of 11. But fluorouracil was really poor, so that's why that whole combination actually never worked for him. So this is just a summary slide. As I already mentioned, that organoids does maintain the tumor heterogeneity and physiology. We confirm that through genomic sequencing. And we test at least up to 43 drugs for a full plate, including doctor's recommendation, standard of cancer, genomic landscape, FDA approval, and more of a comprehensive targetable list. And we could detect at least in 70% of cases with multiple lines of therapy and no known druggable biomarker, we could still choose a candidate therapy which can be actionable beyond their genomic report. And this is our sample requirement. We asked at least 4 cylinders for the core biopsy. Punch biopsy is the most hardest one to grow, I would tell right away. And fluids at least 250 ml. And if there is a surgical resection, 1 centimeter of tissue. Lymph node is harder, but the example I showed you was a lymph node case. But in that case, a whole, close to a whole lymph node would be better because it is normally infiltrated with all like blood cells generally. So this is actually my last slide.
Ali has a question in the chat about the pricing.
Yeah, so the pricing, I think it's somewhere between 5,000 to 7,000, but then we are trying to do insurance reimbursement, and sometimes it can be talked through. So if the patient really needs it, it's not like just because of money we won't do it. So.
And do you have a list of drugs that you would test each time? Sorry.
Yes, so we have a whole drug library of, as I mentioned, 200 for each patient. I do the drug designing part. So I definitely, I'm normally in contact with the doctors or whoever wants to be part of the care team for the patient. So I would provide a proposed, if a full plate proposed 43 drug list. If we can't do 43, we have to reduce the number. Then also I'm in constant touch with the doctor or the patient or the care team that what they would prefer, and together come up with a solid list.
Can a patient order it without doctors or care team involved? Just say, hey, I'm going to get the tissue to you one way or another. And can you do the test if I pay?
Yeah, so at least one doctor needs to be signing our order form or the requisition form. It doesn't matter if that doctor is the treatment oncologist. So we have had multiple cases where the patient is not from Seattle, from other places, they could not get a doctor. So we arranged even, I think, a doctor here locally so that they can get a biopsy, that doctor would sign the form and send us the sample. We recently did even for an international patient, so they would get all the drug treatment in USA, but then it was hard for her to travel, so she got a local doctor to sign the form and send us the thing. So we can work that.
Okay, last question from Rick Stanton. He's got a question in the chat there. Rick, whatever.
Yeah, olaparib is a drug that's being proposed by Tanya Dorf at City of Hope for a CDK12 mutation. And I don't know whether it's really a match. I don't think anyone knows if it's really a match. It's kind of a match. Is that olaparib something you can test?
Yes, we test olaparib.
Thanks.
Yeah, we test 4 different PARP inhibitors: niraparib, olaparib, talazoparib, rucaparib, and we also test beliparib, which is not very effective now. So
I'd rather have you test it than, have
yeah,
me test
then
it.
you go through the whole pain. I understand that.
Oh, wow, it didn't work. Sorry, bud. Thank you.
I know.